the Board Quality and Compliance Committee meeting to order at just about noon. And Sharon, can you note who is here and who is online, please? Roll call. The agenda was sent out. Is there any additions? Okay, can I have a motion to?
Move to approve the agenda.
A second?
That's you, Lisa.
Lisa, are you seconding?
Yep.
Thank you. Okay, there's nobody here in the room for public participation. I don't think there's anybody online, but if there is, please speak up. Everybody received the minutes from November 7th. Any questions, comments on those minutes? If not,
I move to approve. I read the minutes, so they look good to me.
okay. Lisa, for some reason, we're not hearing you. I see you click on, but could you repeat? I'm assuming you second to the motion.
Are you guys able to hear me?
Now I can, yeah. Can you confirm that you're seconding the approval of the minutes?
Oh, yeah, I just had some noise in here and I couldn't hear very well. Can you hear me?
Yeah, we can hear you. Yes. Thank
Okay,
you.
all right, thanks. I'm just gonna close my door a little bit. That way I have a little less noise.
I'm gonna move on to old business, the first being quality dashboard.
Thank you, Madam Chair. Okay, I'm just going to go through this. You all had a chance to look at it. There is only, you'll see on 2025, we'll be changing some of the goals on our dashboard to reflect the changes in what we're measuring this year. And I do have one change. Thank you, Chair, for pointing this out to me on the safe care, improve hand hygiene observations. The goal was 88%, and as noted in the infection control plan, that is not at risk. We did meet and exceed the goal at 92%. So we will be making a change on our dashboard at that, and we have met our goal at that also. And then if there's any questions on the dashboards, these are the closeout for calendar year 2025, and I'll answer any questions on any of them.
Question. I know it's challenging to get people to respond to evaluations. So on page 6 for the HCAHPS, do other facilities, have you checked with other facilities and if they have anything they do that helps with that?
Some of the areas we're able to use text messaging. HCAHPS this year is changing the number of questions, and there are changing up the reporting on it. So hopefully we'll be able to get a little bit different reporting on it, but it's difficult to get response from consumers out on it. So they push out, and if they're seeing we're not getting enough respondents, they'll start sending more surveys out to a greater number of our patients.
Okay. The tougher ones.
Yeah.
And I did have a question on page 6 again, improving OR start times. I know that's a challenge also, but it doesn't look like there was much improvement from Q3 to Q4.
There hasn't been on that, Chair. The OR is working on an 8-3 on that to improve their start times. Part of that was their Meditech tracking and determining exactly what is the definition of an OR start time and getting the medical staff, anesthesiology and surgeons to agree to it and then get a accurate report out of Meditech. And I know they did a lot of work on that in the last 2 quarters, and they definitely should see some improvement coming on the start times this year because they've been working on that diligently. And it's, Ms. McDowell has anything else to
No,
look
just
at?
reiterate that that's been the biggest challenge is to figure out who's gonna agree on what definition. Some people say wheels in, it starts the time, and some people say it's first cut, so trying to figure out. And there's no when you look it up, most of the time, other hospitals are having the same thing, they just have to decide on what they're considering a start time. So like, for example, the surgeons say, well, if anesthesia is not there, but I'm ready, then why should, so it's that. So hopefully they've come to a consensus to determine what triggers a start time.
Surgeon, I could speak,
Yes.
then it's in aggregate, it's really not a huge problem. We have to measure something, right? And so it's just, it is a definition thing when it is, but it's not a huge problem because if you look at our utilization rates, they're not that high. So if we had patients that were going to hospital Y, that could be a real problem because we're not getting all the cases done that we need to get, but it's not exactly the case. And that being said, it's not a major problem, but should we be measuring? Yes. Are we graded on it? Yes.
Thank you, Ms. Moorhead. Anything else, any other questions on the quality dashboard? Okay, let's go ahead and move on to the workplace safety dashboard.
So this is one that we started in 2024. As you can see, actually, some of our trends are going down, which was great. The other thing that we started this year, which you would think is not a good thing, but we actually had some increased reporting. When we started with our new occurrence reporting system on April 1st, one of my goals for this past year on our safety is to have increased reporting of workplace safety incidences. Part of that was if incidences are not being reported, we're not able to identify and correct issues. So this year, I anticipated a trend of having an increase of reporting. And that's a little bit of what you saw on the trends for this year. So you're seeing a little bit of that happening this year. This was my baseline year of looking at trending because we had never trended our workplace safety in a dashboard for this year. So we have it tracked out by emergency services, inpatient services, and wildflower report this year. Some of the incidences really showed that we had some complex patients, that some of our inpatient units had some complex care patients that really drove some workplace safety incidences. And this next year, we're really going to drive some education and some training for our staff to help them work through some of the care concerns that they're bringing up.
Thank you, Ms. Moorhead. And it is great to see, like you said, you see increased reporting, which is a good sign.
Yes.
Within the hospital. One of the questions I had for goals, and this is on a couple things, are the goals annually or quarterly? Because we look at them quarterly. So just to clarify for myself.
We're setting our goals based on our survey of patient safety. So we do that. That's embedded in our survey that we do with Press Ganey. So each year we are doing that survey annually. So that's where I'm looking at it and getting that pulse back from our employees. So I look at this data quarterly, but I'm looking at my goals annually.
Thank you. Anybody else have any questions? Yeah. Let's move on to the medication dashboard.
On this one, we're not getting any data from our antimicrobial stewardship until we get a new QIO. We were getting our data from Telegen. This is through CMS. They have us be part of a collaborative, and right now they haven't announced what organization we're going to be part of. It was supposed to come out in November, and now they're anticipating us being announced into that group in February. I don't anticipate that happening. Who knows when they'll have that statement of work and they'll announce what group we have. So unfortunately, we don't have our antimicrobial usage right now. We're trying to develop an internal report on that. Other than that, we're looking at our med events by department. Tracking green is good. So looking at where we're falling out. I think we're doing excellent on where we are for our size organization. One thing I am wanting to note is our scan rates. When we went live with Meditech in the emergency department, they started with a scan rate of, I believe it was 35% the first quarter. And now they are almost up to where the other units are. So I want to give a kudos out to our emergency room for adopting the scan rates for person and medication. And they've done a lot of work on adopting a best practice there. So they've really worked hard on that.
Chair, something about the table. Is it Q1 24? The column that says Q1 says.
Yes, thank
Okay.
you.
And this is
Yes.
the calendar year that we're
Yes.
talking about.
Yep,
Okay,
that's calendar year. Yes.
thank you.
Any other questions? Okay. Let's move on to the lab blood culture dashboard.
And this, as you can see, this is one thing with blood cultures. This is what is being collected overall. Of course, anytime that you collect blood cultures, if you have a contaminant in it, it's delaying diagnosis of what is what you're treating. Our goal is, of course, like anything, you want to have a zero contaminant in it. As you can see, we're doing really well over the last year. And right now, we just had a little hiccup with two of our departments, but overall we're doing excellent with our rates. And we're just going to continue working on it. Our lab, whenever there's an increase in a department, they go down and do elbow training, and they'll start working with the department and doing side-by-side collections with the department. So we've had great rates in most departments. And you can see where we started in calendar year 2023 to where we are now.
Any questions? Let's move on to new business and the quality plan.
All right. Thank you, Madam Chair. Okay, my quality plan for this year, I did not make changes substantially to the plan itself. I'm leaving that alone. As you've looked through the plan, what I am continuing to monitor, I'm on page 20 here, Sharon. When we're looking at our goals, we're going to continue with managing our sepsis rate, our fall rates. We're gonna look at our restraint rates, our inpatient seclusion rates. Through Charlie's infection control rate, we're still monitoring our healthcare associated infection rates. We're gonna continue looking at our hand hygiene rates, and then for our Press Ganey safety culture index measurement. The reason I use that measurement is that is how we look at our survey of how our staff feels that overall our organization looks at safety. So we have one more year for our Press Ganey engagement survey, and within that is our survey on patient safety. So I'm hoping to get a 3% increase again over that. This past year, we had a good increase in our index measurement, and I'm hoping to increase that again this year. Things that we are doing to promote that is when we get an occurrence report, trying to actively investigate them, do root causes analysis, and then we do a lot of thank you cards for our report back. So when our staff is getting good catches, we initiated a good catch program. So each month, whoever we deem as one of our best catches, we go to Jerry's and we get smoked salmon and we give a good catch pin out. And then we write thank you notes and send them to our employees' homes for anyone who puts in a good catch of something that didn't reach a patient. So every week we're writing usually about 15 or so cards that we send out to our staff. That's how many just-in-time good catches that they're doing. So yeah, our staff is really doing amazing reporting. For timeliness, we're going to be looking at our emergency admission time below the national rate. We're looking at our overall 30-day readmission rates. And then we're looking with Jeanette is looking at our social determinants of health and our equity data. And this is something that we are going to are required by CMS this year. We had to last year attest that we are working on it, and now CMS is taking it up a notch. So now we're going to have to do more as an organization of embedding more health equity measures into our hospital. And each year we're going to have to do more and more until it's going to start hitting our pocketbooks as a hospital. So we are going to work on our strategies for that and develop a dashboard on it. And one thing that Jeanette and I are going to start looking at are there health equity issues that are affecting our readmission rates and how we can address those. So that's on timeliness. And then efficiency. Kim is working on the OR block utilization time on our start times. And part of that is looking at how long our OR is here after hours. That's where it really is affecting our OR time and our OR staff, because a lot of times our OR staff utilization during the day is really low, but then the staff is here till 8 o'clock, 9 o'clock at night doing add-on cases and that. So how can we utilize our OR appropriately and our staff appropriately? Because this is affecting our quality of life and our burnout for our OR teams and keeping our OR staff so we don't have such turnover in our OR. Equitable screening for social determinants of health. This is something that Jeanette's team does a great job on. And then patient-centered, looking at our HCAHPS percentile, looking at our patient family advisory committee, and maintaining our accreditation and certification readiness. And then the other part of the plan that you'll be hearing more about as we report each month in board meetings is our A3 process, which is our lean methodology. I incorporated that into the plan and our performance and our data collection. So I did make some changes in that on it. And then each month we will be having an A3 presentation in the board meeting, which will be about a 10-15 minute presentation. That is actually a requirement by CMS now that all process improvement needs to go all the way up to the governance and the board level. So now you'll have the pleasure of hearing what our teams are doing at the board level again. We used to do that prior to COVID and then we moved away from it. So we're bringing that back to you at the board level. And that's all.
Question, if I may. The coming up to the board level, is that quarterly or yearly?
For A3 presentations, that's probably going to be at each board meeting. It'll probably be about a 10-minute presentation on just one of our process improvement plans.
Monthly.
Mhm.
And then a second question, if I may, the ER, how are we doing on that? Are we at that 2-hour limit, which is sort of the national standard?
I would have to generate a report. I haven't looked at it recently on how many minutes.
They haven't been having to hold for very long. Usually the patients are pretty good, but we did have a little bit longer wait time admission from the ER in December because the census was pretty high. So there was a couple times they were holding some CCU patients, and some of that was because of staffing as well.
Yeah, it goes by
hasn't been-
minutes.
Yeah, I saw that it was like 124 minutes or something,
Yeah.
the average. I thought that might be the one area where it might be falling out,
Mhm.
so. Thank you.
Any other questions? Let's move on to infection control.
All right. So, based on our joint commission feedback survey, I've been using the same risk assessment for the last couple of years. So I did some research, brought back a new risk assessment, so we're able to more appropriately target the actual risks of things happening. So, in front of you today, I've got, the 2024 summary of our plan and evaluations. So our first, you can skip all the way down to the. I think I had a document that said summary. I sent too many documents here. So 2024, we've got, we had 4 major goals and then other infection prevention activities.
I think maybe page 39.
So our first goal was to improve compliance with hand hygiene. We exceeded our goal of 88%, we did 82%. Some strategies were to make sure that staff were participating in that data collection. And we definitely rode the coattails of OB. OB observes and submits data every day, whereas the other units have decided to do it more sporadically. So OB, because they're doing it on a checklist basis and they're doing it every day, they just overall collect a lot more sample. So you can trust that rate a little bit better. But having a trophy and some like kudos and recognition from me also helped maintain that observation data. I also look at Press Ganey to see, is it a fluke? What do patients say? So out of the patients that report, I only get data from outpatients. So you have your surgical SDS patients, physical therapy also as part of that. And they also substantiate that we do have what they see is high. That's great. Surgical site infections, huge burden to a patient that would have something like this. So we've done really well over the last 4 years, making sure we have really low rates. So our goal is below 0.3 per 100 procedures. That kind of equates to about 3 procedures that would have an infection per year. And we've been meeting that pretty consistently. Some strategies I wanted to implement this last year was enhanced recovery after surgery as like a Bartlett protocol. But that's also sporadically based on surgeons using that. And that is boosting up the nutrition before surgery, doing some education before surgery, making sure hydration is happening and reducing stress overall, and having the patient stop smoking for 4 weeks. That's part of that, broad constellation of recommendations. So I'd like to pick that up again, perhaps in the next year, but might not have enough time. Goal 3, we did improve our vaccination rate. So during the pandemic, we had really high vaccination rates, and just completely fell apart. And last year was definitely probably the first year we started to normalize the flu vaccination rate again. So many people were just like, yeah, I'm done having shots, I'm just gonna wear a mask. So we're back to the same number of people wearing masks and same number of people opting in for the flu shot vaccination. One interesting thing as I've been learning more about Wildflower Court is that they've had a long, like 10 years of very low vaccination rates, which I didn't quite understand that. But this year they went from a flu vaccination rate last year of 38% to 79%. So I was really excited that also the COVID vaccination rate at the nursing home was less than 10 to 15% over the last couple of years since the first year of the pandemic, and that went up to 40%. So that's big.
What do you?
Feather in my cap.
It's just curious as to what the change was. Was it just access to vaccines are easier since they became part of Bartlett, or?
I mean, my rounding over there, doing some more one-on-one talking about people, making sure they would actually commit to saying, yes, I want it, or saying, no, I don't. And then being more fluid with, does it work for you this week, next week, or in a month? And making them kind of also narrow in, yes, I'm gonna get it then, or no, I'm not gonna get it at all. So.
And is that patients or staff?
Staff. Patients, no problem. Residents, no problem.
Yes, I can attest to that. Charlie will make you say one way or the other. That's why our rates are high. All the doctors know that. Charlie's gonna come after you. So you gotta make your call, and that's why our vaccination rates are high. So,
Good job, Charlie.
yes, that's why
People that count.
Wildflower is going up because she's beating them.
PCD, I want that little rate. What does this person say? So yeah, it helps to know everybody. Yes, that's awesome. Also, we have not had, knock on wood, an outbreak at the nursing home, so that's very nice to not have that burden right now. Next, number 4 was the most kind of work I did, but also the biggest failure I think I've had this year, or this past year, was based on the risk of Candida auris and multi-drug resistant pathogens. We just need to scrub surfaces and make sure they're clean. Visually, ATP, GlowGerm, something to see EBS clean it, see staff clean it, and then come back and see if it's actually passing the GlowGerm test and the visual test. So I worked really hard November 23 to March 24, and then I kind of fizzled out because of I lost my lead person on EBS. I really can't do this alone. I really need my minions out there believing in it, doing the checking and coming back. I need EBS management to go and support their staff, see that they're competent, that they do the 7-step clean. So I did a lot of work, staff meetings with EBS. I did Project First Line, which is back to the basics of cleaning and PPE use for EBS. I did the same program with the home attendants over at Wildflower. It just can't get off the ground unless I have somebody on the floor helping me go back and look at that little piece on the bedside table that I tagged with Flowjam. Did it get wiped off? It's a lot of work there, so I'm trying to see how I can utilize this. When we did do this, I had feedback, so I was showing that out of 90 services tagged, 64 were cleaned, and those things that didn't pass, we'd immediately clean again. So it really helped solidify what you can't see as a person cleaning services. Sure, they really embody, drive onto those important basics of cleaning. Also a failure on the Bartlett side is that I didn't have a lot of participation in those staff meetings. So I'm trying to figure out ways to get more information to the staff and make it work and show that they're understanding it. So I'm working with staff development on that as well. Occurrence reports decreased, but again, I think there might be some fatigue here as well. So I need to increase my rounding and really just make sure people can, rather than putting in occurrence reports, this wasn't cleaned. Who cares about it anymore? Making sure I'm there, somebody is caring for it. I'm doing some visual inspections there as well. So that's 2024's goals in a nutshell in our evaluation. So my risk assessment that I did earlier this month with key stakeholders around the hospital leadership, unit directors. This is the actual tool we used. So we weight based on probability, how much will it impact the organization or the patient, and then how prepared are we? And then it's through multiplying these three color-coded columns there, we can see how much of a risk it is to the facility. So the higher the risk on that relative risk score, I want to address it in the plan. So anything above a 35 should be addressed in some of my strategies for the next year. A key component missing from last year's risk assessment, so this one is environment of care and sterilization, high-level disinfection. So that was one of the reasons why we wanted to move to a newer, more targeted risk assessment, and one that was clearly like, what's the risk that we're talking about? Lack of contact isolation, So it's much easier to read across, and I could really ask what people on the ground thought about our risks to the organization.
Can you scroll back up to the top? The question I had was is how did ortho colonoscopies and hysterectomy come through?
So this isn't a top, it's only the top based on where I placed it on the spreadsheet. You're asking why the top risk?
Yeah.
Okay. It is a 38% risk score, but our top risk scores were like 55 to 60%. So green actually means that our risk is lower than last year based on our progress. And one of the reasons for that is we're actually not doing as many ortho surgeries. We're not doing as many hips and knees, those total joint surgeries. And we haven't had an infection last year for an orthopedic surgery. So this is the tool we use to help us rank. And then if you go to the next document, I've got them all risk lined out. So my top risk is actually emerging and high consequence infectious diseases. My next risk is MDROs, Candida auris, exposure in the facility. Then I have influx of infectious patients. So it should be, I think, the next document, sure.
57.
There we go, yeah. So that takes everything you saw in that risk assessment, puts it into kind of the top ones I want to focus on. And a lot of these, the strategies will overlap. So influx of infectious patients and emerging high consequence infectious disease. If we plan to drill what would we do if we had a person with measles in our waiting room? We can target those two risks with one strategy. And I also have outbreak, surgical site infections, and adequate cleaning. You know, those two can be targeted in the same way.
Thank you.
Or just a sort of a comment, if I may. So from the 30,000-foot view,
Mhm.
we do pretty well here.
Yeah.
As a statewide, we're sort of known for how well we do in terms of the pandemic. So I suspect when we had our daily reporting, we had 69 dings or something from our CMS. I imagine not many of them were for infectious disease. Is that right?
Yes.
And then the other comment about orthopedics is unfortunately, I'm on quality, and I know we did have a problem with a lot of infections, and it's good that they're down. The downside is that because some of those complicated patients, we're not doing that surgery here. So from a financial perspective, it's not that great. But from an infectious disease perspective, it's great. And then from the minutia perspective, you know, I know emerging and high consequence infectious disease, we do have TB rates. You know, we're in Alaska, you're right, but we're really sort of part of the lower 48. And we get a lot of people that visit here with Zika. You know, do you really think we're going to get Ebola? It never comes here. So
Yeah,
I would think multi-drug resistant.
You're absolutely right. Yeah. The one where we actually had Candida auris here, and it was on that patient. He was in our ER 5 times, never was admitted. You know, so what is the actual risk to us? Did it actually happen? We have good barriers in place. You know, we've got great nursing practice, good hand hygiene, good use of PPE, but that person is still going to come. So how can we support making sure that when that person comes, all of our barriers, all of our supports are still there? Because measles is coming, you know, it's just. And that patient, texted all my IP friends. I was like, what's going on? That was the same patient. They were testing for Ebola, and it was a travel related, international travel. So those key concepts are something we should practice. Yeah, so
It's not been a problem.
it hasn't, I know.
It hasn't been a problem here. I mean, they had to shut down the OR at Children's Hospital.
Yeah.
Once.
And so, I mean, but it's great to identify it.
I know, I'm right there with you.
I
It's
just don't-
really hard for me to be like, we're fine, but
We need to be prepared. So yeah, it's preparation, it's practicing, you know, what's our policies look like? We can't kind of sit back on our. I'm really thankful to have such a low rate here. I definitely want to keep that up and not get complacent.
especially with our low vaccination rates of things like measles.
Statewide, yeah,
Statewide.
not so much, you know.
However, when you're at end gates, waiting for your flights, it's like.
And everybody's coughing.
Yeah, it's like,
Oh, it's tough. So the last thing I'd like to present to you guys is the new 2025 draft plan. So infection control has yet to give the all clear thumbs up, but I have a lot of red edits on this, also related to Joint Commission's feedback on the plan. So on page 10 of stock.
there's only 6.
So that's a summary. Yeah, here it is. There we go. So go to page 10. So specific to the area here, we have a lot more tourists. Of those tourists, how many are visitors, how many are workers? So I added that data in there. Also, related to global emerging infectious diseases, I put more specific lines there. Patient population, I put average admissions, and I also included our therapy and therapies being addressed here. That's also related to Joint Commission feedback. We had toys that were used for play therapy that we didn't have a policy outlining how we cleaned those toys. So we have not yet, we didn't address it in my plan here as what we have single care patient rooms, but what happens on our mental health unit in the group room, the day room, and then on Bartlett outpatient um, behavioral therapy, what happens there with groups of people or patients interacting together and touching the same things. So address that in the plan. Further on down there, the care, treatment, and services provided, we've included in this plan Wildflower Court and home health care and hospice. So it also says on page 11, the types of the amount of people we are serving in that. I update every year how many employees and care providers we have, or licensed independent providers. It's definitely down over the peak of the pandemic. I think from 900 now to 770 employees. And then the top goals that we will be focusing. So again, that's from the risk assessment. The top goals we've got, prepare for high consequence infectious diseases. So this is a Joint Commission finding. We had to put a policy in place. We didn't have one other than Ebola 2014. So, and then we're going to execute a plan to execute a drill to have that done by cruise ship season start. Surgical site infections is still high on the list. So, and I wanted to use a strategy that would work for the OR cleaning and environmental cleaning risks as well. MDROs is a top risk, so we are targeting that with environmental services being part of a high consequence infectious disease drill. And then we haven't done the donning and doffing return demo in a while, so that will also be under the high consequence infectious disease.
I appreciate that you highlight your changes. It makes it easier while you're going through it. And also that you're having that drill before cruise ship season. Good plan. Any questions? So my last question, it's the same as I did last year, is do you have enough resources and staff to complete what you need to do?
I appreciate you asking that again, because I have a different answer. At this point, no. That is a line item I added to that risk assessment is adequate hours to do surveillance, to do on the floor rounding, FaceTime with employees. I get bogged down with case reviews and I want to share the data that I see that can really help people, physicians using too many antibiotics at the nursing home. You know, sign of that overall, like move the dial slowly in the right direction. And that takes a lot of time. Also the antibiotic use requirement for the NHSN, which is part of the CDC, they want our data. I don't know how to get that. We've been doing all that work, but I don't understand the NHSN part to get all the data we're submitting and how to use it back, you know, make sure like it's all in computer speak. And so it takes me a lot longer right now to use this brain and figure it out. Even though I've been doing it for 8 years, NHSN is a time suck. So no, and then thinking ahead with Wildflower Court and the nursing home. I'm handling it okay, but I can't do all the things I want to do at the quality I want to do the best.
So you need more people, not necessarily, I guess people are resources, but like other tools. Okay.
Yeah, that I don't have to build.
Any other questions? Okay. Thank you, Ms. Gribbin, for that great summary and new plan.
And there is a requirement for Wildflower Court that they have dedicated 16 hours of, at least 16 hours IP each week.
All right, moving on to the environment of care,
Hey,
which isn't Mark.
it's not. Mark is unable to be here, so we presenting for him on his behalf. Sure. So there's 6 management plans for the EOC: life safety, campus security, medical equipment, hazardous material and waste, environmental care, safety, and utilities management. So each year we're evaluating objective, scope, performance, and effectiveness. There haven't been any significant changes to any regulatory significant changes. And so there's no changes recommended for any of the 6 management plans. I'm not sure how it is on here because I haven't seen this.
Or if you wanna, you can just go
Best.
through.
Yeah, what page? you need to go to?
So
This is page 81. Is which.
I'll do this. Okay, so looks. For this. Didn't, So, yeah, so we're looking at the management plans. There's no,
Life safety.
there we go. There's no changes to any of the management plans. So I'm not sure how, is it all the management plans?
And these are all, it's a very document.
So the annual evaluation of life safety program. Mark usually will go through the performance measures.
Okay. Maybe, well, I'm hoping that he laid this out the same. So if not, I'll look up on a page and
Yep,
to
that's where you are.
kind of go
Yep.
through this. So the 2024 measurements that we were looking at for
Page
life,
81,
for life safety. Thank you.
Sharon.
As the goals go, reviewing fire drill reports on the EOC subcommittee meeting. The goal was 100%, 90% was met. It kind of goes along with what, I guess, making sure that all of the reports are being submitted to the life safety committee, and the chair is also reaching out for those. Just moving down. So yeah, I'm gonna briefly go through it. So if you have any questions, stop me and we can work. Oh, you just want to do these? Just go. I really want. I can do that.
Oh, that's all you have to do.
Okay.
That's all Mark does.
All marked us.
Yep.
Okay. So for life safety, what went well? Okay, I can do that. So what went well? In 2024, life safety code requirement reviewing, update, and compliant with the current joint commission. Also, for next year, if you ask me to do this, I really need to review this. And then the other one that he wanted to point out, looks like, is the subcommittee completed its 3rd annual fire drills in the OR. So 3 years in a row, we've done OR fire drills now. For surgical services and staff and the providers. So everyone has been participating in those. Thank you. Yeah, so as far as life safety goes, is there any questions?
I do have a question. Can you go back up to 81, please? So looking at the 50% column, not meeting the goals, and it looks like some of that was due just to not having personnel. And now scroll down to the next page. I didn't see some of those items that we didn't meet 50% on. in the new
in the
plan.
new plan.
And I'm curious how those will be addressed.
So in the 50%, the lack of maintenance personnel, we had 4 openings. We've hired 3 now. We still have 1 opening. But we're not advertising for that last opening because we have to train 2 new staff now.
Okay.
And so the time commitment to that, we didn't want to overburden the lead on the training and then trying to keep up on this also. The lead mechanic is also the chair for the life safety.
And the other part of that is in orientation today, we have a new emergency management occupational safety officer. And part of his role will be on the life safety, and hopefully, once he's oriented, he'll be taking a large part of the training in NEO. And he'll be assisting with that and taking up some of that role to alleviate some of that from facilities and helping that. So it's a collaboration with facilities and that occupational safety role. So
Great. Glad to hear it's being addressed. Thank you.
And then the standardizing the fire drill response when reporting for Bartlett and Wildflower, we're taking 2 separate entities and we're trying to make it look the same, all the reporting. So we're currently working through the documentation so that we can make sure that we accurately represent what is actually happening. And it's we're still trying to understand the nursing home and what is required versus the hospital. But we're getting there slowly, but that was one of those on there. Now, why those didn't transfer over, those 50% transfer over to the 2025, I am unsure.
Maybe you can give an answer back.
I can most definitely get an answer back to you. Get an answer back to everybody, and I'll have Gail help with that one.
Appreciate it.
So new in 2025, yep, standardizing the fire drills, and that was one of the 50% ones. We're shooting for 100% this year. Maintaining fire drill schedules for Joint Commission. We're shooting for 100%. I think during our Joint Commission survey, we had some interim life safety oversights, and some of those could have been resolved by fire drills, increased fire drills. And so what we have done is we've looked over the next year and to make it compliant for timing and the day and time and shift, we have it all laid out for our random fire drills. Random being that they have to meet certain criteria. But we do have it all written out this year so that we can follow it. And so far this year, we're at 100%. The last one of the issues that we also had during our Joint Commission was fire stop as it pertains to penetrations through corridors. And what we have a few staff that were that went through Hilti certified training, but all the staff left. And so now we're currently in the process of getting more staff trained up so that if we see something, we can call it out and we can get it fixed. Any more questions on those for life safety?
Does anybody have any other questions?
Okay.
Next.
we're gonna go to page 88.
So this should be campus security. Okay. Okay. being that we touched on the performance measures, we'll just touch on the performance measures just a little bit. Some of the benchmarks for 2024 were developing a written strategy for the duress portion of the SARA system. Not met. Okay, yeah, there. So it wasn't completed, continues development process in 2025. So that one looks like it's 2025. Reinstituting swarms to measure status knowledge. Mark and I both have been part of many meetings on swarms and how they're going to be implemented throughout this next year through all the different management plans. And so that is definitely going to be, if we go down to the 2025. There we go. So we're shooting for 100% completion rate. What we're doing, and this kind of goes through all the different plans, also management plans, is clinical areas, we're going to be swarming twice a year. Non-clinical areas, we're going to be swarming once a year so that we can manage each department as it relates to the management plans.
Question.
Yes.
I mean, these are acronyms that I've heard swarms in the past in terms of mitigating risk or something. If you could just tell me what SARA is and swarms, do you know what those?
The SARA?
Yeah, what is that?
So the SARA system is that it's a system that it's implemented for providers, some providers, and I think maybe a provider can help a little more on this one. I'm not really familiar with it, but it's a system that allows staff to be able to push a button if they're in duress. It'll call over, depending on how it's set up. It will either call over radio, it'll call over the intercom system, it'll page, or it's just however it's set up for the different pieces of it.
Does it stand for anything? SAR? It stands for something, but it also is for all of our monitoring of all of our critical systems also.
It's a
So if there's a danger or a code blue or something.
No, it's for like our boilers, if they have like monitoring on, so if one of them alarms off, but they also have a button that you can wear and you can push it too. So it'll give you an alert.
Facility.
Right.
But it stands for Situational Awareness and Response Assistant, SARA alarm. And so, if I may, Chair, when we first started this, we were trying to look at a mechanism in which, how can we get big staff feel safer? And so we started with these personal duress alarms, and that's part of the SARA system, is that the employees can, and they have repeaters throughout the hospital at the campus. And so we had started initially with the ER and I think Med-Surg years ago. And it's a button about this big that they can wear, and you can push it down for 3 seconds and then it'll overhead page emergency response, ER room 1 or emergency response Med-Surg 23 or something. And so, or I'm not sure what it says, but it does, it says employee duress alarm is what it says. And then it identifies the closest direction that person is at. So then everybody on each unit is assigned to respond to a code blue or a code or fire or a duress alarm. And then mass people go to that area because that indicates like either maybe a patient has an employee in a chokehold or, and then on MHU, they have ones that they can wear on their wrist. And then they have a system in MHU where it just activates within that department because sometimes they just need help within the department, but don't want a big rush of people coming to the unit. And then from there, that system was built out and it can help with notifications for other things in this. So it's not just a facilities thing. It's started out as an employee safety piece. And then that system has the capability to grow and incorporate other things in there. So for example, if we have an employee hits a SARA alarm and it's not silenced in 30 seconds, it will keep alarming. And then if it continues to, I think after 3 minutes, then it triggers our alarm system, which then calls the police and then they automatically arrive.
We can move on to what went well. So on-the-time competency training for safety, security, incident, short and on-board training of security officers and has ensured a uniform response in their words and actions during these events. And kind of, if you have any, please, if you have any questions, just ask. I'm kind of just going off of what Mark has highlighted as what he was going to present. What has been accomplished, increased training standards has brought increased morale. So within security has been able to keep their employees happier.
Madam Chair, if I may, I'd like to add some of this if I could. I'd like to thank the entire organization for providing additional protective equipment to our security team. They hadn't had in the past. They now have been provided with some flashlights for illumination. They've been provided with cut-proof vests as well as cut-proof gloves. And that was something that was done in this past year. That's not included on there, but I feel like in my conversations with our security team that they feel more comfortable just knowing that they have some level of protective equipment. So it's an exciting step in the right direction.
Yeah, we have to thank the hospital for allowing us to purchase those because they come at some cost. So if we move on to
93.
medical. So as part of for the medical equipment, the 2024 you look across there, so reviewing and updating the risk one, so the most critical pieces of equipment. That by the end of the year, it was 100% completed. And within the new system, so and pieces of medical equipment, one of the other aims that they were shooting for was getting 100. So that second one right there that shows 0 on it, it was due to the system of materials management and facilities not having a system in place to be able to identify pieces of equipment as they come in for price. Yeah, the inventory, making sure we know what we have at the hospital, the price, how long it's going to be, the life expectancy of it. It's a system that they were hoping for, and it just never came out. So as we move on to continuing measures for 2025, we have. And this is that big part of the swarming again. So we have a new system that we're going to start working with for swarms. A new program that we have to help us identify the clinical areas, go through the clinical areas twice a year. That's what I was saying earlier. We have, I'll go with Walsh Track. That's the new system that we're going to be using. We're learning how to use it because it's not quite built to how we need it to be able to manage our facility the way that we would like it to be. And so we're still kind of working through that process with the company that provides us support.
And that program is gonna definitely help out me.
It will.
There's a lot of overlap with primary care in my rounds. So I'm eagerly waiting. What it is essentially the checklist I have on a piece of paper of what I need to look at. It just helps you kind of streamline your round to target what actually needs to be looked at, see if there's a problem, for with medical equipment, who cleans it? Is it cleaned? Is there any buildup on stuff? So those are the things I'm looking for too with this 2025 plan.
Yeah, and it really engages the department directors so that they're taking responsibility for their units. One of the things that went really well for 2024 was, Frank, one of our biomed technicians, finally got certified as a biomed equipment tech. So he went and got himself certified. And so that was a big benefit to the hospital for what he'll be able to do for us.
Did you have somebody come in and do?
No, he traveled to Anchorage for that testing.
But did somebody come in to do the biomed checks previous?
So our current supervisor is also certified.
Okay.
So now,
You have two.
so now both of our biomed certified technicians. Also, we've replaced all the Zold, the fibs, and the AEDs throughout the hospital to create consistency. Any questions on medical equipment master plan?
101.
Hazardous materials, waste management. So when I was looking through this, one of the things that was very evident was that all of these questions that were presented as our performance measures are all being based and measured through Relias, through staff development. These are questions that are being asked as testing those questions after the training has been provided. So what was hoped for as a benchmark coming across, you can see that most things were very close to being met, some exceeded, but some short. So in the 2025, it's just there are a few that are the same questions that they're going to keep. One because of the low score it was, but new questions are being generated so that you can't just through the training, you actually have to participate and learn from what's going on so that you can answer the questions and be graded appropriately. What went well? Assistance from committee members in nursing units to ensure compliance with pharmaceutical disposal. Now, this is something that we have one of the subcommittee members is part of the maintenance department, and he regulates. He's the one that does all of the transporting of the hazardous materials. And one thing that went well is that we've maintained volumes to remain a small quantity generator. So that means the staff isn't just putting that pharmaceutical waste in to gain pounds. They're properly disposing of it in the appropriate bins, which is keeping us a small quantity generator.
Let me interrupt. I have to go back to the office. Is that going to be a problem in terms of motions or anything like that? Are we good?
We have Lisa.
Okay.
You tell me, we're good?
Yeah, we have Lisa, and then you have de facto.
Okay,
Thank you.
thank you.
So any questions on? Hazardous materials?
Anybody else questions? 111.
Yeah, moving on to safety management plan. So being that he was key players last time, let's just look at what went well. I don't think anything in this is So what went well? Yeah, what went well? Group focusing on environmental care safety went well. A lot of this still, right, we're dealing with security and how they're doing. And then what has been accomplished, we are implementing that rounding software, that Walsh tracking is a big piece of, I'm going to say it again, it's a big piece of all of the management plans coming up. Does anyone have any questions in the safety management?
Ask you the same question is, do you have the resources and the manpower to?
So right now they have filled, they're waiting on their last, I believe their last employee. They're 100%, so they'll be 100% staffed. They still have 3 openings for casuals. And so they're doing a lot better. I know that, talking with the supervisor, he's made comments about always needing more. But currently, with where we're standing right now as what has been approved, we're 100% staffed.
That's a question. Okay,
Chris?
Yeah, can you hear me okay?
yes.
The question I had, and I think Travis, you already mentioned the successful implementation of the WPV. That's the Welsh tracker. Is that correct?
I'm just saying it's a
Chris,
standard workplace violence.
It was page 112 under what has been accomplished, successful implementation of WPV tracking. Is that the same thing as what you mentioned with the Welsh tracker? I'm not familiar with the WPV
Workplace
acronym.
violence, I think is what they're talking about it.
So 2 different things.
did you hear that, Chris?
2 different things. Okay.
Yes.
Okay. So then
Yeah.
my question is, what is WPV?
WPV,
Workplace.
workplace violence.
All right. Thank you so much.
Anything else for Travis?
You have one more.
Oh, one thing.
One more. That's all right. This is the last one. So the last one being utilities management plans. So this management plan is one that we've been working on, especially the performance measures for 2024. We've been working on some of these performance measures for years. We've had one casual, and that's all he's been doing since he started 3 years ago. And we finally have completed the inventory control program for maintenance. So all of our inventory is within our work order system, so that when we create a work order, when a work order's been created, we do it, we assign parts to it, it actually takes it out of inventory. It prompts us when new inventory is needed, so that we can make sure we have what we have on hand when we need it. Also, the blueprint scanning, Kelvin, who has retired as the maintenance supervisor, worked very diligently on that. And we find that we've completed that to the purpose of what we are trying to do, getting all of it digitalized in the computer so that we can have digital copies of all of our blueprints. The other one that we fell a little bit short on, but it's all because of staffing issues, is going through relabeling all our circuit breakers so that we can easily identify what is within a panel, so that if we have an issue, we know where to go, we know what to turn off. Most of them are accurate, but we were finding some old legends with handwritten, you know, almost like home, right? With a bunch of handwritten stuff. And so the idea was to go into these, identify them, rewrite them, double checking to make sure that they're correct. For 2025, coming into the new year, we have a few new buildings that we really need to get up into our system so that we can manage them appropriately for utilities. And so what we've done is we've taken the quarters of this month and kind of said, okay, this building we're going to audit and we're going to go throughout the year so that we can, by the end of the year, 2025, we'll be able to have audited and have all of those new utilities within our database. And then, with that, following that would be making sure that all of the staff is appropriately trained on each of those pieces of equipment so that we can maintain them appropriately. We do have some pieces of equipment that are past their life expectancy. The ones down towards the bottom, the utility systems that already identified as obsolete, those have already been approved. And I guess Joe can correct me if I'm wrong, but Mark just told me this morning that those were already approved as part of deferred maintenance because they're pieces of equipment that have to do with patient care. So just a few things of what's been accomplished.
I think that was a yes.
Oh, that was a yes. Oh, thank you. Thank you for letting me know.
I'm pretty confident that's a yes, but
Okay.
I said I'm pretty confident that's a yes.
Well, yeah, anyways. So a few things that were accomplished. One of the main ones was new fuel delivery system. So our fuel delivery system, we weren't able to utilize what was an appropriate amount of fuel coming out of our storage tank. We were only able to retrieve about half of what we had available to us. And so we've improved that system with new lines, new pumps to allow us to draw well down into we end up stopping like at 8,000 gallons. At a certain point, it's just whatever the generator requires, that's where we stop, but we didn't want to push that. So we tested to where we feel very confident that it's a working system now. The other piece that we really identified, part of Joint Commission survey, was with penetrations with different things we found above ceilings. We've implemented an above ceiling work permit for contractors and staff so that anyone who accesses anything above the ceiling has to fill out where they're working. And then so that maintenance or somebody can be a second set of eyes to make sure that, yes, it is put back together the way it should be so that we don't get cited during any surveys. Any questions as it relates to utilities?
I have one question about labeling the panel boxes. Is that gonna be, it's fallen off here, so.
Oh, it's something that is identified and we are still working on, but we're working on it not as part of the utility management plan. One thing that we have already done is we've gone through every panel and we've identified every spare breaker and have shut them off and have labeled them, have put tape over them, labeled them as spare. And that was one thing that kind of was cited in Joint Commission, our survey, as we had some that were in the on position and they have to remain in the off position. So as the first piece of labeling and going through the going through the circuit breakers is to identify what is spare. And we've accomplished that. That was a big piece of what was identified. We found some to be labeled spare, that weren't spare. And so we've had to go back in and relabel those. And so so at least now we know that all the breakers that are on are in service. And now we just need to go through and start doing the second piece of that, which is identifying. And what we're doing is whenever we have a project, we're making sure that as part of that project, the panel being relabeled is a piece of it.
So there's a plan for it.
Yes.
And they came in and resurveyed us, and that was one of our sightings on our joint commission. So when the life safety came back, they had to inspect the panels. Check. Yes. Job.
Anything else? that I
Any other
can answer you
questions?
today? Any other questions?
Thank you so much for being here.
Oh,
Yeah,
absolutely.
thank
My
you.
pleasure.
Okay, case management is Jeanette.
Thank you, Jeanette.
Hi there. Sorry, I had to come off of mute.
127.
Okay. So mine is short and sweet. We have a utilization management plan that is required by CMS, and we just had to do a few updates to it. And this is basically how we work with the payers and the providers for reimbursement and how we address any sorts of issues that we're having with that. So I guess I'm going to pull up the summary of edits on my computer. And then if you want to just scroll to the plan, that will probably be easier. There's just a few edits. We updated the review date, obviously, did that this past November. Our QIO, our Quality Improvement Organization, had a name change. If you want to scroll down from Keepro to Essentra. So we just updated that. And then when we talked about, thank you, observation. Okay, that's good, thanks. We provided a little bit more detail in here between an ABN when we give a patient advanced beneficiary notice and when we give them a HIN. Advanced beneficiary notice is when a patient comes into the hospital under observation status and they don't meet inpatient level of care. And this is a Medicare letter that we give them that says that they'll start to be responsible for their bill after 2 nights. And so we just kind of outlined that a little bit more here. And then inpatients, Medicare inpatients receive an important message from Medicare that says that they have the right to appeal their discharge if they don't feel like it's a safe discharge. They can appeal that with the QIO. And if that is upheld, then we give the patient a hospital issued notice of non-coverage, which tells them that they'll start to be responsible for their bill. And for non-Medicare patients, they can also receive a hospital-specific HIN without the important message. Those are only specific. The important message is only specific to Medicare patients. And then further down, we talk about our secondary physician advisors. Okay, there you go. Thank you. So when we're looking at medical necessity and there is any sort of concern or discrepancy with the team, we can submit the case for review to a physician advisor or the UR committee for concurrent review. And we added the physician advisor because we have a provider who is serving in that role. So that was added this year. And then I think the only other stuff was the updated reference or the updated references. And then we had previously had in the plan our tracking reports, but they're changing a lot. So we took those out of there since they're changing more than annually, how we're putting those together. And that's it. Does anybody have any questions on the utilization management plan?
No questions from this end.
For me.
Okay,
Thank you.
thank you.
Thank you for being patient, Jeanette. Karen, if you could go to the motion on page 134. Just requesting that the quality committee move all of these plans to the full board for approval. And there is a suggested motion at the bottom of this memo. And I was hoping if Lisa could make the motion.
Yeah, mute. Yeah, she's muted. Lisa, can you hear us?
I'd have to. Yes, member of all committees.
I move the Quality Committee of Bartlett Regional Hospital to approve the Patient Safety and Quality Improvement Plan, Infection Improvement Plan, Utilization Management Plan, and Environment of Care Plans, and forward them to the full Board of Directors for the Bartlett Regional Hospital for approval.
Can I second? Does there have to be? Okay, I'll second that. Okay, any further discussion we need to have in regards to this? I think you guys did a great job again in putting this together and getting us information. I really appreciate when you highlight the changes that are being made. I appreciate the formats that the information has come in. So say the motion has been approved. Anything else, any committee comments?
Do you want to, actually, since Dr. Rester isn't here, I would love for the committee to entertain setting a date at for the year, maybe looking at your board calendar, maybe setting a standardized date would be appropriate.
And I see that you were looking at the second Thursday of the month.
That was my suggestion, because I was looking at finance and planning have kind of set days.
How about I'll check with Lisa and Dr. Raster if that works into their schedule. Do you have a second option?
I think Lisa talked about she is good after 3 o'clock, and I know Dr. Raster has his OR day on Thursdays.
Okay.
So if we did it on a Thursday after 3, that might be,
Okay, I'll check with both of them and then I'll get back to you.
Did we not set the, this morning at governance?
well, we can do it bi-monthly. This committee was set bi-monthly, so that would be a March
Perfect,
date.
perfect, because we set it in February.
Yes.
You're right.
Anything else? Okay, during the meeting, thank you guys.
And then March would be clients heavy.
Hey, is Mark in today?
Yes.
Oh, again, so
This is the one.
3 o'clock.
DHS was interested in it.
It's a quarter to.
So I know that.
Yeah, that's how-